150 PubMed articles and contributed chapters in internationally renowned textbooks. She's also very active as a Joint Secretary AIOS and Vitreoretina Society, Scientific Chair of the Karnataka Ophthalmic Society, and recipient of the Best Paper Award. Over to you, madam.
Thank you so much for having me. It's real itself is a big challenge in these patients. So my topic is on recent advances in pseudophakic CAV management. Pseudophakic CAV management, I think most of us are at a point where we are only treating them with injections the minute we diagnose him. But is there anything that we can do better for the patient is what I'd like to cover. No financial disclosure. So how big is the problem really? Overall, the incidence in Indian patients, the clinical CME is seen in at least 2% of uncomplicated cataract surgery. We would think that it's only seen, where we encounter complications, not really. And angiographic CME, which means that those with diabetes, you can see at least in 55% of them with pre-existing diabetes. So that means when we come up with worsening of the pre-existing edema. So that's the major point here. So capillaries and then eventually accumulation of fluid in the intracellular spaces of the retina. So this is an image that shows very clearly what really happens there with or without a breach of the capsule. So you have a lens implant and then you have post-surgical inflammation. This is a pointer. No, I don't think this works. Okay, so basically, what we need to look at is this, the post-surgical inflammation that leads to inhibition of the prostaglandin clearance from the aqueous. So when that happens, it accumulates in the anterior chamber, and from the anterior chamber, it diffuses into the vitreous, and that becomes more easy when the PC is ruptured. Once that reaches the vitreous, what happens is there's a breakdown of the blood-retinal barrier, and then the cystoid macular edema develops. So this is how is the pathogenesis. Now, when you look at the classification, based on when it occurs, it could be either acute when it occurs within 4 months and late onset when we see it after 4 months. Very good vision patients can still come back. Chronic CME is when it lasts for more than 6 months. Now, what are the risk factors? Intraoperative complications, I think all of us are very well aware. Trauma to the iris. The previous session spoke in depth about the floppy iris and how you can keep having the iris come out through the wound. That's again a big risk. Posterior capsular rupture, intraocular lens dislocation, vitreous loss, incarcerated vitreous, cortical remnants in the vitreous, iris fixated or anterior chamber IOL itself can give rise to some amount of inflammation. But it can, I must reiterate, can occur even after an uneventful cataract surgery. Hence, monitoring is very important and especially so in the patients with high risk factors. These are the patients that are meant, pre-existing ocular conditions, diabetes mellitus or even PDR. Any history of retinal vein occlusions, the edema can recur, epiretinal membrane, neovascular AMD, retinitis pigmentosa. So all these conditions are high-risk patients. Preoperative use of prostaglandin analogs. And this is the next big worry for us because a lot of patients respond only to PGAs, but then we all know that they can cause increase in the CME. So if you're already using this for a particular patient and you see a new development of CME, then maybe it's time to switch the drug. Untreated elevated intraocular pressure is also known to be associated with post-operative CME. So how do you diagnose these patients? You have both clinical and imaging. Clinically, it's quite simple. You can actually, on a slit lamp biomicroscopy, see the cystoid spaces very beautifully. If you can see stereoscopically. And of course, OCT has become our biggest tool in the armamentarium to treat any sort of edema, and particularly CME. So with CME, you start seeing fluid accumulation in the inner nuclear layer, which then migrates to the outer plexiform layer and then finally subretinally. So with the high resolution OCTs now, you're actually able to figure out where the exact fluid lies, the intraretinal and the subretinal fluid. Multicolor imaging is another way for us to pick up. This is a multicolor imaging on the spectralis. Again, you can see the cystoid spaces very beautifully. Angiography, pooling of the dye in the cystoid spaces there, and then you see the flower petal pattern. Very commonly that we use to describe cystoid macular edema. Opta is a new diagnostic tool that we are seeing now. You can also see, contrary to what we believe, that there is some reduction in the vascular perfusion. Though we assume that to be only in diabetics, we also see it in pseudophakic CME. But the one good thing here is that there is reversal of that decreased perfusion with time. So that's the major difference between the two. So what are the different treatment modalities that we have? Topical, oral, injections, laser and surgery. So this is a very nice table that is there from one survey article which has given us almost all the treatment modalities and what is the study design that is used to prove each one of them. So a lot of them, as you can see there, are for refractory pseudophakic CME itself. So these are some of the drugs that I'll be speaking about. So topically you can use either NSAIDs or interferon. NSAIDs rapidly permeate to the cornea and the sclera and they can block the inflammatory mediated breakdown and therefore they are useful not only as treatment but also as prophylaxis. When administered prior to the surgery and continued for 4 to 8 weeks after surgery based on each individual practitioner's preference, it helps definitely reducing the risk of development of post-op CME. Now with respect to interferon, our team at my institute in the UVA department have actually worked on topical interferon and particularly they have seen it for pseudophakic CMEs. They found it to be non-invasive, economic and effective. This study was primarily done in those patients who had PCR intraoperatively. Mean duration of complete resolution was in about 5 weeks and topical therefore is an effective medication. So this is a paper that we published from our team at the UVA department in IGO. These are some of them. This is for inflammatory macular edema. This is the topical interferon for the treatment of pseudophakic macular edema when you are looking for other options. The only downside is that you will have to prepare the injection, prepare the drugs for the patient. So this is how it's made. You'll have to buy this Intalfa, the company one, and you make the drops for the patient in the institute and then give it to them. So the next thing after topicals is oral drugs. This is not a sustainable option, maybe just as a short gap option because patients are so uncomfortable taking acetazolamide. But this particular study, the next few slides are basically from this study, which is the current management options in urban gas. This is also a systematic review. This was published in 2021. They found complete resolution in close to 90% of the cases and 100% of them when they were treated with a combination of oral acetazolamide, NSAIDs and steroids. Now coming to steroids, I think this is one of the most popular medications for the management of CME. You can either use implant devices. Implants are effective in the sense there's better patient compliance because the duration of efficacy is much longer, but then we have the risk of raised IOP. What are the options that we have? We have periocular, we have subtenance, suprachoroidal injection also of triamcinolone acetonide that's being done. And then you have the intravitreal injection, the DEX implant or the IVTA. IVTA is extremely useful but unpredictable. Sometimes it lasts for 2 weeks, sometimes it's there for 6 weeks. So we really don't know how to follow up these patients. This study particularly said that 30% of eyes required a second injection after anti-VEGF. Again, a very useful drug for CME. The only downside being that as against the implant, you'll have to inject monthly, but they do fairly well as well, and about 15% of them require a third injection. The single most important advantage over steroids is that there is a less risk of IOP rise in these patients. Now coming to laser, we would be worried about treating patients because it's a central macular edema, whether you can actually do laser. Yes, subthreshold micropulse laser in repetitive short pulses in subthreshold mode definitely is an option compared to our conventional laser treatments. When you use a 577 or a yellow laser, treatment with 7x7 grids is quite helpful in these patients. And that particular study has demonstrated resolution of the retinal edema and improvement in the BCVA as well. Now, last is surgery. This has to be kept in mind because when there is vitreous adhesions, nothing else works. None of the medical management will work. Whether there is vitreous adhered to the iris, to the cataract wound, and sometimes you don't have support, place an SFIO, other methods that you can help the patient with. Now, we did a pilot on biomarkers. So, we've spoken about anti-VEGF, we've spoken about steroids. We know that the primary target of VEGF was same patient who underwent the same injection in a gap of 2 to 3 days. This was the risk. There's some change in the inflammatory biomarkers. So, we know that mediators in inflammation are primarily these, and they affect the retinal vascular permeability. So, when they were either undergoing intravitreal injections or intraocular surgery, Once that is done, we run the CBA or the cytometry B-Dere method. You can find out multiple factors here. You use something called as a flow cytometer for this. So once you get that, you get a quantified composite report. So what we found was that cytokines such as ICAM, BCAM, IL-6, IL-8 and MCP were increased in the persistent macular edema group, which means that they were not going to anyway respond to anti-VEGF because the amount of inflammatory markers was much higher compared to the VEGF load. So that means we definitely have a non-VEGF mediated pathway, which got us to then bring something called as a biomarker kit. This is a work in progress. With this, we plan to actually test out the tear samples. We're collecting tear samples through the Schirmer strip, and then we use 300 microliters of extraction buffer and do this entire process again. The advantage of this kit would be it's a point of care kit wherein you don't have to depend on a lab. You just have to, you can actually run it as a batch sample of 48 or 96 or multiples of that. You can run it as soon as you collect some samples. Here again, what we see is soluble factors such as pro-inflammatory, pro-angiogenic and the anti-factors. So we have done this for tears, aqueous, vitreous and serum, and I have the results for the aqueous humor only, and you can see the difference between controls and diabetic retinopathy patients, how high they are. The reason why I put up this is because you're also going to discuss other types of CME in the next couple of talks, and we've not yet done it for pseudophakic CME, but I'm hoping we can do it as well. So I'd like to conclude with this particular case. This is a 76-year-old gentleman, lasered stable PDR with CME in the right eye, 618 vision, incomplete resolution after 1 month of follow-up with anti-VEGF. So that's why we subjected this patient to the soluble factors, and what we found was a very alarming increase in actually the IL-6 and IL-8, which made us to think that since the inflammatory markers are so predominant, why don't we give IVTA? And just after 1 injection of IVTA, it was a complete resolution. So I think this is potential, for personalized medicine or targeted therapy rather than trying everything because one size doesn't fit all. So to conclude, pseudophakic CME is more common than we anticipate because it's underreported. Patients don't really come to us. Advances in OCT and OCTA should actually allow non-invasive detection, quantification and monitoring, and especially high-risk populations should be screened even before the development of vision symptoms, because I think when we treat them earlier, they tend to preserve their vision better. So prophylactic treatment for CME, improvement in the technique, prevent vitreous humor loss as much as possible, perioperative NSAIDs, avoid the use of topical PGA in patients with high risk, and a significant need for new IOP lowering agents that have no risk for CME worsening. And this is when you have to refer to retina. It's a rather complicated slide, but I'm not saying that every patient needs to be referred to retina, but at least if you have tried persistently for at least 2 rounds of treatment, the patient has not responded, or if you think that the patient needs surgical management, then definitely refer to a retina specialist. Thank you so much. That's my clinical and my research team for giving me this opportunity. So moving on to the topic, anatomy of macula and investigations in cystoid macular edema. So macula is a 5.5 mm diameter area in the posterior pole, which is bounded by the superotemporal and the inferotemporal arcade, and it is centered 4 mm temporal and 0.8 mm inferior to the center of the optic disc. So these are the components of the macula. From the center we have the fovea, then the surrounding parafovea and the perifoveal region. Fovea is a 350 micron diameter area, which is the centermost part, and it is 150 micron thickness. And then the center we have a depression known as the umbo, which is responsible for the foveolar reflex. And they contain densely packed cones, which are elongated and thin so that maximum number of cones are accommodated. The fovea centralis is a 1500 micron diameter area. It contains the foveal avascular zone with the average diameter of 500 microns, and also it contains the Henle's fiber layer. These are the Muller cells and photoreceptor axons that goes obliquely from the nucleus towards the synapse with the bipolar and the horizontal cells. Now we have the surrounding parafovea and the perifoveal region. They surround the foveal margin. They are thicker. They contain several layers of ganglion cells and bipolar cells. Now about blood retinal barrier, we have an outer and an inner blood retinal barrier. Outer blood retinal barrier, it refers to the barrier that is formed by the retinal pigment epithelial cells by their tight junctions, and they regulate the movement of solutes and nutrients from the choroidal circulation to the subretinal space. Inner blood retinal barrier is located in the microvasculature. It is found by the tight junctions located between the capillary endothelial cells. So, cystoid macular edema contains, there are two fundamental filtration rate is equal to the rate of fluid removal from the extracellular retinal tissue. When there is a disruption of the blood retinal barrier, more and more fluid is accumulated within the inner layers of the retina, mainly the outer plexiform layer. So, why is the outer plexiform layer more involved? It is because it is in the watershed area that exists between the retinal and the choroidal circulation. So initially the outer plexiform layers, later on sometimes the inner nuclear layer also gets involved. Now the accumulation of fluid mainly occurs in the Henle's fiber layer. Normally the Muller cells extends from the external limiting membrane to the internal limiting membrane. It is important for the structural integrity of the retina. In the Henle's layer, it almost runs perpendicular to the receptor cells. So here the retina loses its compact nature, and this laxity enables the fluid to be accommodated in the macular region. And this is responsible for the classic petalloid pattern. Now coming to the investigations, most important is the retinal examination by a slit lamp biomicroscopy. You can use the 78, 90D or a 60 diopter lens. We can see intraretinal cyst within the foveal region of the macula. Now red-free image is also important, mainly to demonstrate the changes in the internal limiting membrane and the nerve fiber layer. We can see the typical honeycomb pattern and also the changes like epiretinal membrane or a vitreomacular traction. Now fluorescein angiogram, in the early phase of the FA, we can see capillary dilatation in the perifoveal region, and later on the leakage into the cystoid spaces because of the radial distribution of the Henle's layer, and it is responsible for the petalloid leakage or the honeycomb pattern. In some cases, there will be late staining of the optic disc, conditions like intermediate uveitis, Irwin-Gass syndrome and birdshot chorioretinopathy. OCT has gained importance because of its non-invasive nature. You can measure the thickness of the retina. It is almost inversely proportional to the visual acuity. We can also see the intraretinal cystic areas, and the features of this will be, there will be no hyperreflective border, there will be a clear cavity, and we have a petalloid arrangement. In severe cases of cystoid macular edema, we can get subfoveal fluid also, and we can also demonstrate conditions like vitreomacular traction or epiretinal membrane, that is the hyperreflective band can be seen on the inner surface of the retina. In OCT angiogram, shows cystoid spaces in the superficial capillary plexus, and in the deep plexus we can see cystoid spaces. We can also demonstrate the enlargement of the foveal avascular zone, and we can see areas of capillary rarefaction in the perifoveal region. Now autofluorescence imaging is a non-invasive technique, another important technique. We can see hyperautofluorescence in the presence of areas of fluid accumulation. So this is because of the dispersion of the macular pigments in areas of intraretinal fluid, and they will unmask the autofluorescence by the lipofusion in the retinal pigment epithelium. So that's all. Thank you.
First of all, I would like to thank Dr. Srini for giving us this chance. So I will be cystoid macular edema. So mainly two diseases, that is diabetic CME and CME in retinal vein occlusions. Other vascular conditions include CREO, MACTEL or vascular tumors or hypertensive retinopathy. So pathophysiology of diabetic CME is that there is a breakdown of blood retinal barrier, loss of pericytes, hyperglycemia, oxidative stress, release of inflammatory mediators. All these results in the fluid leakage and CME. So diabetic CME, that is the most common cause for CME. Around 55% of CME is due to diabetes. How you can differentiate from other types of CME is that you may be seeing associated signs like microaneurysms, hard exudates, epiretinal membranes, vitreomacular tractions and all. The importance of cystoid edema is that the size and location of cyst influence the visual prognosis, so it becomes an important biomarker. Now let us see how this CME acts as biomarker. So the size of cyst, that is larger cyst and location, outer nuclear location indicate poor visual prognosis, because there is already photoreceptor damage and more of macular ischemia. So you can divide cyst into small, large and giant depending on the size. And the bridging retinal processes between the cysts actually indicate a good vision prognosis. And one more classification based on different studies that the ratio of central macular thickness and the cyst indicate the visual prognosis. So if the cysts are occupying more than 90% of central macular thickness, that is a poor prognosis. We call as type 4 disease. And along with that, you have to assess the integrity of outer retinal layers. That is the external limiting membrane and the KSOS. If both are disrupted, it is grade D disease. If there is no disruption, it's a grade A disease. So all these are based on different studies. So in this example, you can see the last one is 4D. That is, the cyst is occupying more than 90% of central macular thickness, and also there is disruption of the external limiting membrane and the KSOS. So that indicates a poor prognosis. So cystoid macular edema acts as an important biomarker in diabetic macular edema. Now, what is the OCTA findings? Both the cyst and ischemic retina appears as non-perfused black areas, but the cysts are more blacker, but the ischemic retina is more of greyish in color. And also the vessel density in the superficial and deep capillary plexus plays an important role in prognosis. Both are reduced in diabetic patients, but the superficial capillary plexus changes indicate more of macular edema, while the deep changes indicate more of progression of diabetic retinopathy. And also we can assess the response to anti-VEGF, whether the vessel density is coming back to normal with your anti-VEGF treatment. That is also important. Now, FFA still has a role in diabetic CME because most of the diabetic CMEs are associated with macular ischemia. So you can see the enlargement of foveal avascular zone, you can identify the areas of focal leak, and some patients there will be asymmetry of diabetic macular edema. You will see edema only in one eye. That may be due to a macular BRVO. So FFA still has a role in diabetic CME. Now, how will you differentiate a diabetic CME from pseudophakic CME? So in pseudophakic CME in OCT, the cysts are more in inner nuclear, and there will be usually presence of SRF, and also you will see the hard disk in FFA in the late phase. The other signs of diabetic retinopathy, that like microaneurysm, hard X-rays will be seen in diabetic CME, and also more cysts are seen in the outer nuclear layer with disruption of the outer retinal layers. So the treatment, more of nowadays it is more of intravitreal anti-VEGF, not much role of grid lasers, intravitreal steroid implant, and also vitrectomy in recalcitrant diabetic edema. Along with that, you have to control diabetes. The renal function should be assessed, and control of lipid profile is also important. Now, BRVO, 30% of BRVO patients will have CME, and here also the mechanism is ischemia causing damage of blood retinal barrier, treatment by anti-VEGF and steroids. CRVO, hypoxia and inflammation results in breakdown of BRB and macular edema. The most common cause of visual loss in CRVO is due to CME, and in this, if there is associated subretinal fluid, it indicates a bad visual acuity. And OCTA shows more of cyst in superficial capillary plexus in CRVO, but more in deep capillary plexus in BRVO. These are the OCTA findings. Treatment again, you can give intravitreal steroids, anti-VEGF, newer anti-VEGFs, Ozurdex. But even if the macular edema becomes normal, the other factors like metamorphopsia, stereopsis and contrast sensitivity may not improve even after your injections. CME in CRAO is actually very rare. If it is seen, you should rule out an associated venous occlusion, and also you should rule out choroidal ischemia. Hypertensive retinopathy presents as bilateral CME. It can present in type 4, in grade 4, that is in malignant hypertension, and actually it doesn't need any ocular treatment because it improves with control of hypertension. MACTEL is a disease which can be type 1 or type 2. Type 1 disease behaves like coarse disease. There is increased permeability and leakage, which results in cystoid macular edema. Treatment is PDT and anti-VEGF. While type 2, you can see cystoid spaces in OCT, but it is more of degenerative changes not fluid accumulation, and you can get disruption of the outer retinal layers like KSOS. Certain vascular tumors, choroidal hemangioma, it can be well circumscribed or diffuse, and usually it is seen 70% occurs in macular area, and it can be associated with cystoid macular edema, and you have to treat it with PDT. Then hemangioblastoma, usually seen in bone Hippolyndus disease, and 11 to 50% are juxtapapillary in location, and this can present as cystoid macular edema, treated by PDT or intravitreal steroids. Thank you for the
Thank you, Dr. Pappa, for that illuminating talk on vascular disorders. Another important topic is pachychoroid diseases. Over to Dr. Sunil, Professor R. Yogian, for this talk.
In fact, CME is not a diagnostic finding in any of these diseases, but CME may be there. So you are getting a pigment epithelial detachment, like here. And you are getting, so when this pressure further increases, it breaks open the retinal pigment epithelium. Now the fluid comes into the SRF and you get a classical CME. We are getting another, get fluid, but the fluid will be very minimal. And you may get in fundus autofluorescence or as an FF. So there is no gold standard for the treatment of chronic CSR. Actually PDT, because it remodels the choroid, so this is a viable option in the treatment of chronic CSR. Because this PDT is not a very safe treatment as you think, but it has got its own complications. So to reduce these complications, you have a safety enhanced treatment, that is half dose or half fluence PDT that is used. We know CSR is actually probably caused by the stimulation of the mineralocorticoid receptors in the choroid. So you can also use anti-mineralocorticoid and agents like spironolactone, so many other things, even rifampicin, all these can be used. Another common disease, that pachychoroid disease that we come across in our practice is polypoidal choroidal vasculopathy. This patient may come to you with complaining of reduced vision. When you see the fundus, you will see orangish nodules. These orange nodules will be diagnosed. This ICG angiography, which is diagnostic of this condition, you can see that corresponding to the polyps that you see, you will see the pigment epithelial defect. Corresponding to the branching vascular network, you will see the double layer sign. So this is almost like, this is diagnostic of PCV, and this should be done every case where you see orangish nodules on the fundus. And FFA will give you, if you do only FFA, you will get a finding like an occult CNVM. So these patients may have SRF, these patients have CME. CME probably is not diagnostic. It doesn't signify anything. It signifies only one thing: disease is active. So this is another patient who has been treated with multiple PDTs. You can see FFA showing the classical fluoropetal pattern and OCT showing the cystoid macular edema. So treatment should be initiated for every patient who is symptomatic and is having active PCV. And you can consider treatment for patients who are asymptomatic but active. So you can consider treatment for that, but all those with active and symptomatic PCV should be treated. One sign of active PCV is SRF. There are so many other signs. There are no internationally recognized criteria to find out which is active, but these are a few of them where you will see loss of vision for more than 5 letters in a TDRS chart, SRF with or without cystoid edema, PDT, subretinal hemorrhage. All these suggest treatment for PDT. You know, treatment for PCV. We don't know which is ideal treatment for this PCV. Many agents are being tried, even anti-VEGF agents like aflibercept, promising results. PDT can also be tried or in combination, but we don't know which is the best. Another novel pachychoroid disease where CME is seen is peripapillary pachychoroid syndrome. Here the pathology is same like the CSR. What happens is only the peripapillary choroid is thickened. So what happens? The peripapillary choroid and the choroid which is nasal to the macula but not temporal to the macula is thickened. So what will happen? The fluid will push the RP only in that area. So you will get findings only in the area between the disc and the fovea, but not beyond the there is no disease in the temporal half of the fovea. So this patient, the same pathology as in CSR, but it is only seen in the temporal, only in the nasal half between the disc and the fovea centrum. If you see the OCT of the last, the findings will be same, just like fundus autofluorescence will show hypoautofluorescence, FFA will show you the window defects, and ICG will show you dilated vessels only between the macula, fovea and the disc. OCT will tell you very clearly that these pachychoroidal vessels are there only nasal to the fovea, and you see the chysis or you see the cystoid macular edema, it is only nasal to the macula, the sparing of the retina temporal to the macula. This is again a novel pachychoroidal disease. So what happens now? The fluid has come into in pachychoroid disease, the fluid has now come into the subretinal space. From there it has come into the intraretinal space. So cystoid macular edema will develop. Now this fluid will percolate into the optic disc so that the patient will have disc edema. So there are three classical features of this disease. The patient may have SRF, patient may have intraretinal fluid, that is cystoid macular edema, patient may have disc edema. Mind you, this fluid will fluctuate by its own. Within days, sometimes the CME will disappear by its own. So you can always wait in this patient rather than jumping and treat these patients with anti-VEGF agents or any other modality. It may disappear spontaneously. The last of this disease is focal choroidal excavation. You can see focal choroidal excavation is actually an excavation of the choroid. You see the OCT, you can see an excavation of the choroid. The patient may present with reddish vision. You may see even a neovascular membrane there. Actually, that focal choroidal excavation, what you see here is the focal choroidal excavation here. It's actually produced by the traction of the retinal pigment epithelium by the scarred choroid. But to call as focal choroidal excavation, you should not have any other disease which is likely to produce focal choroidal excavation like a staphyloma or a scleral disease. So if it is seen isolated, that is thought to be congenital, but a patient will be symptomatic only by around 4th to 5th decade. What happens is that focal choroidal excavation actually causes the damage of the choroid capillaries. So if you do fluorescent angiogram, you will see ICG angiogram, you will see initially hypofluorescence. Later, the pachychoroidal vessels there will leak. So in the later phases, the ICG angiogram, you will see leak. Initially, you will see hypo, later you will hyper. This choroidal excavation actually causes damage to the Brooks membrane and the RP layer. So when you do FFA, you will actually see a window defect there. And these patients may be associated with cystoid macular edema. So this disease is generally a stable disease. It does not require treatment. You require treatment only if the choroidal neovascular membrane develops like this. Only then you need to treat these patients. So otherwise, it's an isolated finding. Thank you.
Retinal vascular bed leading to excess accumulation of fluid within the macula is manifesting as cystoid macular edema. These are the important causes of inflammation that is associated with cystoid macular edema, that is intraocular surgery, uveitis and laser procedures. Among these, uveitic macular edema is having a worse prognosis. We have discussed pseudophakic CME in detail. The importance of PCM is that in 80% of the time, it will resolve spontaneously with a very good response to topical therapy. But uveitic CME is having a worse prognosis. Its treatment is always challenging. The CME will persist even after control of intraocular inflammation, leading on to structural complications associated with significant visual loss. It is seen in 30% of patients with uveitis. Cataract surgery is always a risk factor, especially if we are doing the surgery in presence of active inflammation, will definitely lead on to cystoid macular edema. So, any type of uveitis may be complicated by CME, but it is most commonly associated with intermediate and posterior component. Among pediatric age group, intermediate uveitis and juvenile idiopathic arthritis are the most common causes of cystoid macular edema. Worsening of always a non-complication of PRP. We can decrease the development of macular edema by doing the PRP in multiple sitting or treating the macular edema prior to PRP with anti-VEGF or focal laser. NDI capsulotomy, especially if we are doing the capsulotomy within 3 to 4 months of catheter surgery, will definitely lead on to development of CMA. So if you are seeing a cystoid macular edema clinically, you have to do a thorough clinical evaluation in order to find out the signs of inflammation or any sign of intraoperative complications like the posterior capsular rent or sulcus fixated IOL, etc. More than the defective vision, it always decreases the visual function by decreasing the color vision and contrast sensitivity. We have to do a thorough slit lamp biomicroscopic fundus evaluation, especially if we are using green light. You can see this, better visualization of the cystoid spaces. FFA is still the gold standard in diagnosing PCMA by demonstrating leakage from optic nerve. It distinguishes PCMA from other causes of cystoid macular edema. In uveitic CMA, it helps to find out inflammatory CNVM, macular ischemia, neovascularization in the retina, or occlusive vasculitis. This is a picture of Behçet syndrome showing fern pattern of leakage from retinal vessels. Optical coherence tomography is a non-invasive procedure we usually order in all cases of CMA. The importance is that it is very helpful to pick up even the subclinical case of cystoid macular edema. It helps to assess the visual potential of the patient by ruling out macular complication, especially chronic complications like lamellar hole, ERM, or VOT. Some of the biomarkers described in uveitic macular edema include integrity of the ellipsoid zone entry. These are having better correlation with the visual potential of the patient. These are some of the pictures. Here, first picture, you can see with this birdshot choroidal retinopathy, typical CMA, sarcoidosis, and it is very helpful to identify the inflammatory CMA. In chronic cases, we can see epiretinal membrane, vitreomacular traction, lamellar, or even full thickness macula. Some of the other ancillary investigations include FAF associated with increased FAF and OCTA associated with larger foveal avascular zone associated with CMA. So we have discussed the management of PCMA, so I am discussing more about management of uveitic macular edema. So intraocular inflammation is the actual pathogenesis, so the mode of treatment is of course anti-inflammatory agents. These are the various options available. In mild or subclinical cases, it will better respond to topical treatment alone with or without subconjunctival steroid. So before starting the treatment, we have to consider some points, that is laterality of condition, status of the lens, whether the patient is steroid responder or glaucoma suspect, what is the age of the patient. In all cases of CME, we have to rule out infections before starting the patient on steroid. Then we have to rule out structural complications like ERM and VOT because it needs surgical management. So if there is moderate amount of inflammation, after ruling out glaucoma, in a case of unilateral disease or asymmetric cases, we can do pedibulbar steroid, especially posterior subtenon injection of triamcinolone acetonide. Even after multiple injections of pedibulbar steroid, if it is CME is persisting, next choice is intravitreal corticosteroid, especially in case of severe inflammation. Recent trials have shown better response to anti-VEGF agents in refractory uveitic macular edema. In recalcitrant macular edema, or if there is any contraindication or complication with systemic immunosuppression, the mode of treatment include intravitreal implants. These are some of the trials showing better response to implants than intravitreal or systemic corticosteroids. In sight-threatening or bilateral cases, always first line of management includes systemic corticosteroid. We have to start the patient on high-dose steroid in order to get the control of inflammation, then slowly taper over a period of 3 to 4 months in order to avoid the recurrence of cystoid macular edema. If the patient needs long-term steroid, like in severe inflammation, for example Behçet disease, sympathetic ophthalmia or leakage, we have to start the patient on immunomodulators like methotrexate, azathioprine or MMF. Even if the patient is not responding to immunomodulators, next choice is biological agent including anti-TNF-alpha agents. So what are the options in refractory uveitic macular edema? If there is structural complications like epiretinal membrane, VM tube or macular hole, definitely the mode of management is pars plana vitrectomy osteotomy, and some of the trials have shown good response to systemic interferons or octreotide or tocilizumab in case of severe inflammation. So to conclude, if you are seeing a uveitic macular edema, always rule out any infection because we are treating the patient with systemic corticosteroid. So then, if the patient, if it is mild, especially associated with anti-uveitis, it will respond to topical treatment with or without subconjunctival steroid. In unilateral cases, according to the severity of inflammation, after ruling out glaucoma, we can give peribulbar or intravitreal steroid. In all cases of bilateral or chronic cases, mode of choice is systemic corticosteroid. So, inflammatory CME, we have to do a thorough clinical evaluation and thorough follow-up of the patient in order to pick up the complications early so that with PPV, the patient will be having a better vision. Thank you.
Thank you, Dr. Geeta, for the elaborate Professor of Ophthalmology, Government Medical College, Idiki. She will
Maybe due to some toxic abnormality of the cell, or it may be simply because of the retinal pump mechanism getting damaged. So it is seen in retinitis pigmentosa and other diseases which are mentioned here. So again, as I've told you, there is damage to the cell. It's within the cell, the space has increased, and fluid is within the cell and not outside, so it does not leak from the vessels. And therefore, it is absent on FFA, so OCT gets to be more important. And nowadays, we have a much wider view with OCT with a dense raster scanning, so we are able to get much more details of the fluid. So the disorders can be genetically linked, and the most common genetic link is the retinitis pigmentosa. So majority of this CME in retinitis pigmentosa is of course central, and there is no vascular disruption as I've said, and it affects vision. It may not be, the thickness may not be related to the vision. So the causes may be ERM or toxic products from the retina. That is, the RPE is damaged. So from the degenerating RPE, there may be toxic products. And the treatment of all these disorders in which there is accumulation in the intracellular space is, first line is topical or oral carbonic anhydrase inhibitors. And second drug is steroids, which can be oral or local or intravitreal. And lastly is anti-VEGF. So how do you give these steroids? Oral steroids, 500 milligrams per daily. You're tapering it slowly to 125 milligram every 3 days. And usually you need to continue this for 1.5 months at least. And similarly, topical dorzolamide, 2% TIE. For 1 year, you can give oral steroids, deflazacort, and otherwise intravitreal injections. And sometimes ranibizumab intravitreal. So as you can see here, the 6 weeks or 6 months usage of topical dorzolamide has decreased the CME. Similarly, you can see an intravitreal injection of IVTA of dexamethasone actually has given improved the CME. Again, vitrectomy, what is the use? It relieves the traction, it improves oxygenation to the patient, layers of the retina, and suppresses the release of inflammatory substances. In juvenile X-linked retinoschisis, many of us have seen it, where you see a pattern like this, where you see spoke wheel pattern in the macula, and you see multiple layered inner retinal layers of cysts. Again, this is because of a genetic damage in which the retinal layers loses adhesions. So that way it starts splitting in multiple layers. And again, treatment is carbonic anhydrase inhibitors. A very similar thing is myopia. A patient with high myopia with sudden loss of vision, and you sits on the slit lamp. There is an unexplained visual loss. And this is seen in patients who have a posterior staphyloma. What you see is the split of the retina like this, a dome-shaped macula with a split like this. So this again, treatment here, steroids or drugs will not help. You have to go in for vitrectomy. 2 drugs which are important, one of them is the drug-induced, of course, they're bilateral. And once you stop the drug, the CME improves. But if you don't, it can cause macular degeneration. One of the common drugs is niacin or nicotinamide, which is the active agent. Niacin is a treatment for lipid disorders, and usually they used to be given as high doses for 1 year, 6 weeks to 1 year, and you have maculopathy, which is first diagnosed by gas, and it occurs within 1 month to 36 weeks. And the reason for this is Muller cell damage, and nuclear metabolism is disrupted here. So what you get, cystoid spaces in the inner nuclear layer, and the foveola appears bright yellow in color. So there is no leakage on FFA, and as you can see, the inner nuclear layer and later the outer plexiform layer shows cystoid spaces, and the treatment is stopping the drug. Another drug which is important is the anti-cancer drugs called the taxanes. Now they are paclitaxel, and this is for ovarian cancer and esophageal cancer, etc. And possible mechanism is RPA damage. Again, treatment is cessation of the drug which causes improvement. One problem is multiple myeloma. Now in multiple myeloma, you can get a syndrome which looks like CRVO. This is called the hyperviscosity retinopathy. Here again, it is not leaking on FFA, but you get CME. If you see the CME on OCT, it is quite a big CME, but on FFA it is quite silent. This is because of accumulation of immunoglobulins in the disease into the retina. Treatment is very poor treatment, that doesn't help much. And another important, of course, cause is phototoxicity. When you are operating in the operating microscope, there is a chemical and a thermal damage if you are using too much light for a long period of time, especially after intraocular lens implantation and especially after multifocal IOL. So what do you get here? On the FFA, you will see some hyperfluorescent spots. They don't leak, but you get hyperfluorescent spots. And on OCT, you get cystoid macular edema. You can try and avoid it by making an oblique light, decrease the intensity, decrease the exposure time, and after implanting the IOL, try not to use too much time. And multifocal lenses, of course, are a worse prognosis for that. So management is if you can get filters, UV and infrared filters in the IOL as well as the microscope, and reduction of surgical time.